kind of what I want to talk about is where HIV medicine is at the moment and where I think we might be going. And maybe kind of where medicine in general is going. So let's start with Albert Einstein. Concern for man himself and his fate always form the chief interest of all technical, scientific endeavours. And he admonishes us to never forget this in the midst of our diagrams and equations. And maybe this quote from Roosevelt, the test of our progress is not whether we add more to the abundance of those who have much. It is whether we provide enough for those who have too little. And maybe the perspective of medicine that kind of should base us in caring for those who are needy. I'm going to move on from that particular, those comments because our time is actually quite short. Well, what is the ethical basis for public health? Well, it stems from really a knowledge of the environment and socioeconomic circumstances that constrain the decisions individuals make about health. This affirms the obligations of governments, of communities, to protect and improve the health of all their citizens. Its basis is the assumption that all lives are of equal worth. And the task of us as physicians, as doctors, and I think you guys, and I can see there are nurses in the group and other folk who are in the broader medical profession, our task is twofold: to understand the patient and to understand the disease. And the comment is that there's a well-tried clinical method for understanding disease, and we teach our students to do that. We ourselves go through that particular kind of training over, in some cases, in my case, 37 years, and some of you, a lot less. But there's no equivalent method of understanding people, our patients. And that's often the place where we come adrift. Don't know if you're familiar with Friedrich Wegner, novelist from the USA, and whose own background comes, he's a theologian, a priest, and a writer. And he makes this comment: until you cannot read the story of Adam and Eve, of Abraham and Sarah, of David and Bathsheba, until you can read the stories of our society, of who we are as humans, the mythologies, the basic fabric of who we understand ourselves as human beings, as your own. Muhlenberg said, you have not really understood it. This man did his theology in New York, and in that particular book, he mentions Muhlenberg, the theologian, who, as he teaches them as they were young men, women, at this particular college in Harlem, became these characters, as he kind of went through it, and his arms would flagellate around, and the man would become the particular character in the Old Testament that he was describing. And I would maybe urge you that until we begin to understand our patient's story as somehow a part of our own, that this man or woman in this bed, the story that I'm hearing, in some way is part of my own story, part of myself as a physician. We've not really understood their story. Sarah, 48-year-old, lived and worked in Gauteng for 20 years. Known hypertensive, had a cardiovascular accident, a stroke in 2010, treated at a public hospital here, but was left with a hemiplegia. She was unable to continue her work and had to return to her home in rural Mpumalanga, where she had grown up. had referral letters from the hospital here in Gauteng to receive occupational therapy and medication, and she moved into the family homestead in Mpumalanga with her sister's children, and some of her own children and even grandchildren. Homestead was situated on a hill about 4 kilometres from a tarred road. This is a lady with a stroke. The homestead had no running water. There's a pit latrine. This remembers a lady with a stroke. Sarah had previously provided most of the family's income, and she was no longer providing any income. Sarah was visited by the community caregiver who advised her to take her referral letters to the local clinic. She explained that Sarah should apply for a disability grant, and also noted that this would not be an easy matter. Perceptive. It was difficult for Sarah to get to the clinic. One half of her body kind of refused to move. And when she did manage to get there, the rehab team was not available. She was given an appointment to return in 5 weeks. A nurse took the referral letter, and due to the unavailability of a prescribed treatment at her clinic, she was prescribed an alternative, a first-line treatment according to their standard guidelines. If you've been to these rural clinics, as I do, make a habit of it in my job to go to rural clinics, you'll understand that the drugs you get there are not what you're getting in the big clinics in Gauteng. The nurse indicated that she was not able to refer Sarah for a disability grant as the forms needed to be completed by the doctor, and the doctor would only be coming the following week. The effort involved in getting back to the clinic was too great. Family discussed what to do next. They considered traditional medication or a visit to the local GP. To see the doctor at the clinic would have meant 2 more visits. The family decided to spend their money on the GP. The GP said that Sarah needed to go to the local district hospital with a referral letter stating that she needed occupational therapy and a grant. I hope you see that we're going round in circles, friends. When they got to the hospital, a sister shouted at them for not going to the clinic first. Sarah was told to go back to the clinic and still had no referral letter for occupational therapy nor for a grant. HIV strips individuals, households, networks and communities of assets. We're talking about people in South Africa. This is a true story that I've just given you of Sarah, by one of my colleagues working in Mpumalanga. We're talking about what really happens at the ground level. Sarah is not HIV positive, but many of my patients, in fact most of them, almost all of them, are. And this particular comment that HIV strips individuals, households, communities of their assets is very perceptive indeed. And indeed, if we look at our situation kind of globally, you'll see that Africa has a problem. And this is data looking at maternal deaths, looking at children under 5 deaths, and adults and children living with HIV. And you'll see on the right-hand side that we have a problem in sub-Saharan Africa. And if we look at our Millennium Development Goals, and what we ought to be getting to in 2015, I think it is, you'll see that we are nowhere near where we ought to be in terms of under 5 mortality rate, and in fact getting, and the next one, let me just move that forward. There we go. And in terms of maternal, likewise, we're not actually achieving what we need to achieve in Africa. There's a social gradient in health that runs from top to bottom, where inequalities in health are avoidable yet not avoided. They're inequitable, unfair unjust. And this is Michael Marmot speaking, one of the major movers in public health worldwide. The experience of the poor with their governments generally has been negative. People expressing an experience of powerlessness. And if you think, for instance, for the miners in London in the last 2 weeks, that powerlessness kind of leads to a sense of, hey, there's nothing except violence to turn to. I want to go through a look at, this is from a New England Journal of this last week, the 23rd of August, just looking at 10 and 11-year-olds. Very nice, very good article in the New England Journal, looking at a large number of youngsters, and 5,000 of them randomly selected in the schooling in 3 different locales in America. And this group evaluated different measures, witnessing physical assault, witnessing threats, and so on, and found, and this is a fairly complex graph that they give us to look at, but what I want you to know is that the diamonds kind of give you a sense of the mean, where white children are at. And these are black and Latino children in these different schools in America. And what is very apparent is at every level, virtually every level, black and Latino children are at risk. And the independent contributors to these disparities, particularly, are household income and the level of education, or the lack thereof, of the parents of that child. And the conclusions that they come to, we found that harmful health behaviors, experiences, outcomes were much more common amongst our black and Latino children than among the white children. Adjustment for socioeconomic status and the child's school, and the school often reflected that socioeconomic background of the child, reduced most of these differences or disparities. Once you took those particular elements away, interventions that addressed potentially detrimental consequences of low socioeconomic status and adverse school environments may help to reduce these differences in child health. So the experience of health is impacted by our socioeconomic background, poverty in particular. And I think that's driving a lot of what I see in the peripheral areas. When I go to peripheral clinics across the country, I'm seeing men and women and their children who are poor and can access nothing else than the local clinic. And as a result of that, come away often with medicine that is second best. When we look at women, and again, Michael Marmot discussing the role of women, the feminization of the AIDS epidemic in southern Africa indicates a lack of power of women to participate as equals in the social freedoms of men. So issues that are pervasive and that underlie the experience of HIV in our part of the world. And then governments. Your government may seriously damage your health. And that should be obvious to all of us. And indeed, when we look at war in particular, and this is a comment from me, the Mail and Guardian some years ago, this Saturday or last Saturday, US death toll in Iraq, past 2,000, Iraqi death toll, 200,000. Obviously, by the end of that particular war, the numbers were much, much higher, and the disparity between US and Iraqi would have been that much higher. So governments do. And maybe reflecting on that, in terms of governments, maybe we should look at the National Strategic Plan. 2007, our government committed to providing an appropriate package of treatment and care support services to 80% of people living with HIV and AIDS by 2011. That has not yet happened. And yet, clearly, a lot of money is being consumed in the process of trying to deliver care. Why do governments seldom deliver on their health promises? Well, Reinhold Niebuhr, in fact, one of the lecturers of Friedrich Buechner, the American I mentioned a moment ago, and one of the great minds of the 20th century, kind of looking in his day, 1932, at Stalin in Russia, Hitler in Germany, the rise of these totalitarian regimes, makes a point. Politics will, to the end of history, be an area where conscience and power meet, where the ethical, coercive factors of human life intersect and work out their tentative and uneasy compromises. And maybe that goes on for the duration of humanity on this planet. That's the point here, that democracy, the creeds and institutions of a democratic society, have never become fully divorced from the interests of commercial classes. Think again of London, of the mining houses, the people who control the system, who indeed have a very democratic kind of background, and yet have interests, commercial interests, who conceived and developed these particular creeds and institutions. And what I think Reinhold is saying to us, look behind the image in front of you and ask yourself, what is really happening in society? And in HIV, one's kind of, from the ethics of HIV, obliged to ask those kind of questions. As I say, in terms of poverty, I see it in our rural areas, and it's in our cities as well, whether you go to Deep Sloot or whether you're in any of our areas around and in our cities. Well, the burden of disease. We are one of the economic powerhouses of Africa. We spend a fair bit of our GDP on health, and yet we don't have the outcomes that we would be anticipating. We have a big burden, and maybe that's part of the reason why. We have TB and HIV and AIDS, high maternal child mortality. We have also non-communicable diseases, violence and injury. So there are reasons why it is difficult maybe for us to get to the outcomes that we're looking for. When we look at our data, life expectancy, this is last year and the year before, clearly we've not made a huge amount of progress, but maybe we're a little bit better, say, than Zimbabwe or some of the countries, Swaziland, around us. But we still have significant problems in terms of mortality of our infants, mothers, those living with HIV and AIDS, fair number of those. Some would argue that may in fact be higher. These are from our stats and antenatal surveys. We have significant problems. Our gross national product certainly has come up over these 20 years. We have improvements that are quite significant in terms of living conditions in a number of areas. Yet our unemployment, our population living on under $1 a day, and our population not on medical aid, not on kind of a form of social support, are significant. So we have problems in our society, all of which impact on health in our society. Going back to a report that I presented a minute or two ago, and this is from WITS data in our villages and our households in the northern part of the country, Limpopo. You'll see that in that small rural area, people really live off the land. 20% harvesting insects from the bush in order to supplement their diet, and so on. And what was found in this particular study from WITS, the adult mortality related to or gave rise to decreased food security, decreased likelihood that maize would be grown, and often resulted in lost wages and reduced disposable income. Significant effects that HIV is having in rural communities in South Africa at this particular time. This is prevalence of antenatal, and I hardly need to remind you that the data is awesome when you look at those sort of numbers of our young women who are HIV positive. When we look at mortality, and in this age group of 15 to 49, this is what we're looking at, whereas it ought to be down there. Kind of frightening data. And again, in terms of maternal, we're looking at this slice, almost all due to HIV and AIDS. And with regard to South Africa, and particularly the comment that this particular report made, South Africa, one of 12 countries in which child mortality rate has increased instead of falling since 1990. So we have, in our community, in our part of the neck of the woods of Africa, yes, we have things to be proud of, but we have a lot to be frightened and anxious about. And this really is just going on with those kind of same comments. So I want to move on and look at another study which I found, again, quite helpful, looking at rural and at urban communities. Inequitable access arises if barriers are systematically different for people with different levels of social advantage. And this report from, again, our public health people in Joburg, Durban, and also in Cape Town, looking at availability, affordability, and acceptability. Three kind of rubrics to examine: availability, the mode, cost of transport, travel time, waiting time at a facility; acceptability, perceptions of staff, attitudes, cleanliness of the clinic or the hospital, length of queues, the judgment or the stigma of the community; and affordability, overall expenditure in health care, and including the money required to reach the antiretroviral facility, expenditure on self-care, where they didn't get enough antiretrovirals or whatever it was in the clinic and then had to buy out of pocket their own medicines, expenditure on other providers, as you saw with Sarah. It's not good enough at the clinic, so she had to go to a GP, and so on. Three aspects: availability, affordability, and acceptability. This was a study of 4 sub-districts in 4 provinces of South Africa, 1,200 antiretroviral users interviewed, with a view to establishing what barriers there are in accessing care. This was back in 2008, and these were the 4 sites. You can see that 2 of them are urban, 2 are rural, and these were chosen as sites because they were different. Some of them were, in fact, hospital and doctor-based, but Hlabisa, for instance, there was a district hospital, but the service was nurse-based. So there were different aspects in these different particular clinics. And this is rather busy, and I'm going to quickly I've in fact put in red the things that I think you might want to look at. Travel time, and these are in minutes, to get to your clinic, 74, 66, and urban, a lot easier to get to. So already in people who live in rural areas have a negative that they have to get over to get to the clinic. Sometimes transportation by foot, here 5%, and that really means that in order to get to a clinic in Bushbuck Ridge, you have to get transport. You can't walk there. And you have to pay money, clearly, to do that. And so that there are disparities and differences in communities throughout our country. Waiting time, and maybe you might just to look at those minutes, 200 minutes, 200 minutes, that kind of, let me see if it spells out, there we go, in terms of mean time for waiting in blue, you can see almost everywhere. Whether it's urban or rural, you kind of, if you're poor, you had to wait 2.5 hours, or just over 2 hours, to get to see the doctor. There's an added time, if we go back to where we were, there's an added time waiting to collect your medicines. So maybe if things aren't quite so bad at Helen Joseph after all. I mean, I've kind of thought, hey, this is the worst thing to happen to anyone. But in fact, when I look at this kind of data, it's around about 6 hours that you're going to spend at the clinic, whether you're in an urban or in a rural area, and remembering that to get back to your home if you are in Bushbuck Ridge is going to take you more than an hour, and you're going to have to wait for taxis to get you there. Kind of, I think, really quite worrisome data. Mean time taken to travel, as you can see in the rural areas, quite a problem. Here, if we look at the asset index and the respondent employed, again, you'll see that there are significant differences between rural and urban communities, as I think you would expect and kind of understand. Let me go through to the next. Affordability. And again, looking at expenditure, looking at, for instance, in Flabisa, kind of northern KZN, that those people there are spending 156 Rand of their total expenditure on self-care, 87 Rand. And what they mean by that self-care is going to chemists and buying vitamins and immune boosters and things that we know have relatively little real effect in terms of HIV. So kind of when we look at these expenditures in our rural communities, you can see immediately that our rural communities are spending huge amounts of money compared to our urban communities, just in terms of trying to access sufficient health care. Acceptability. And this was, again, respondents talking about queues in the clinics and the way that staff treat them. And I guess, as you would expect, there are issues both within rural and in urban communities about lack of kind of acceptability. Many, 80%, these are percentages. 49, 65, 67% of people just waited too long. Just wasn't. They weren't happy with this. I think this is particularly a study that kind of helps me to think, well, David, how do we do things better? How do we provide for people in rural and in Soweto and in Mitchell's Plain, Cape Town? How do we do better? And we should be looking at trying to find answers to that particular question. So if I look at these particular key points that came out of this very good, I think, excellent study. Rural areas, key access barriers to antiretrovirals included high costs of seeking care, not just the care itself was not that expensive, but the seeking of care. For many residents, these costs, as the authors note, were catastrophic. Huge amounts of money, they didn't have them, and as a result, they got themselves into debt, particularly in the rural areas. Stigma, less of a concern to respondents in the two sites that had more decentralized service provision. That was, for instance, Flabisa, where you would go, nurses would look after you, and you would go to a small clinic in your area. Concerns about the acceptability of services could have led respondents to spend their money on other providers and on self-care, vitamins, immune boosters, traditional. So acceptability, maybe we can kind of do something there and improve on that. While access barriers to health care are multidimensional, context-specific, policy-relevant solutions can be proposed through studying these barriers in these diverse settings. So what is health? Well, if we were to look at health in the kind of broad, a state of complete physical, mental, social well-being, and not merely the absence of disease and infirmity, and moving from individual to group to community to kind of society. These are kind of pictures that we're all familiar with and we grew up with when we went through medical school. What is a health system? Health system consists of all the organisations, the people, the actions, whose primary intent is to promote, restore, maintain health. And a good health system delivers quality service to all people, the poor and the more fortunate, when and where they need them. And in fact, we can look at a health system and we can kind of assess it in terms of outcomes and looking at stewardship, human resources, information, financing, servicing, and which is what our NGO, the NGO that I work with, does, and then I'm sure that many other NGOs and the government must be doing, or ought to be doing, as well as ourselves. So we can assess whether we are winning this particular kind of battle in terms of the type of health service that we render to South Africans. And indeed, we can kind of break it up into kind of other component parts, the human resource, auditing, the education, professional development, community health workers. You can see myself training these young doctors in Barberton, single doctor, one-on-one, sitting with him, kind of going through the motions with patients and enabling that young doctor to kind of come up to a standard. That's what we mean by professionalism. So what is modern professionalism? And I want to kind of end with this in the last 5-10 minutes and then maybe draw questions. What do we mean by modern professionalism? It's interesting. I work with, and I don't see my colleagues in the audience, so I suppose I can kind of say what I like. I work with a medical officer who comes to work in a T-shirt with his jeans, which I don't know that he washes too frequently, and they're frayed at the bottom, and what we used to call sand shoes. And they kind of look like old sand shoes that kind of I would have worn when I was a kid. And most of the time when I round with this young fellow, he hasn't got a stethoscope, so I have to loan him mine, and kind of I do rounds, and I think, hey, if I was a patient, I would be running out of the door and looking for another doctor down the road. So maybe professionalism is in part the way we look. But that obviously is kind of only a part of it. And I remember that, that was kind of, when I was in America, when I was a young doctor, you had to wear a tie. I see that no one wears ties today, apart from myself and David. And kind of, but nonetheless, there's a kind of a look about a professional. But more than that, it's the way they do the job that's really important. This comment from Jerome Krugman, professor of medicine in the United States, in Boston, writing again fairly recently, I think it was 2011, we find ourselves learning a new language of medicine, filled with words that seem familiar yet feel foreign. Patients are no longer patients, but are customers, consumers. Doctors and nurses have been transmuted into providers. You, me, providers. These terms are not synonymous, says Krugman. The word patient comes from patiens, meaning suffering or bearing affliction. What doctor would ever want to suffer or bear affliction? You want to get up late, come to work without a shirt on, with a T-shirt, pajamas or whatever. Yeah. In my day, they would have felt the wrath of the professor. Doctor is derived from dotere, meaning to teach. The nurse from nutera, to nurture. These terms have been used for more than 3 centuries. Reducing medicine to economics makes a mockery of the bond between healer and the sick. When we're ill, we want someone to care about us as people, not as paying customers, and to individualize our treatment according to our values. I think a very appropriate comment, but obviously I'm coming from a rather conservative, old-fashioned school. So what is professionalism? And this is Richard Horton, the senior, as you probably know, the senior editor at Lancet. Integrity, compassion, altruism, continuous improvement, excellence, working in partners and teams. Those are some of the concepts that we have imbibed over my 40 years or so, and in your case, over the years that you've been in practice. These are kind of things that I would like in the medical team that cares for me. And I'm sure all of us in this room would agree with Horton. So the definition, medical professionalism, signifies a set of values, behaviours, relationships that underpin the trust the public has in doctors, nurses and healthcare workers in general. Attributes, shared creation of goals, pursuit of knowledge, development of teamwork, growth in leadership skills. There's a sense in which this is what professionals ought to be about. And sometimes we teach that as older doctors in this kind of hidden curriculum, where just as we talk with our colleagues, we kind of teach them about what it is to be a doctor, a nurse, a professional. So teaching occurs through the modelling, and part of our job is to be role models. First comment, the pre-modern society had a reality dominated by religion. So in a sense, God was watching you and you better be careful, so you put a tie on, because otherwise the lightning might strike you. Kind of a sense in which that dominated the ethos. The modern society, in which all of us have been brought up, has been dominated by rationality. So the young fellow who comes in a T-shirt says, but hey, Dr. Spencer, it's all right to wear a T-shirt. I'm comfortable. And I think the patients are comfortable too. And the patient kind of stares at the ceiling. But in the postmodern world, there are multiple realities. So maybe if I come with nothing on, that's my reality. But as long as I've got my stethoscope, which I think is an essential. So postmodernism is characterized by this relativism which we see creeping into medicine. Namely that there's no such thing as objective facts. That reality has a plurality of meanings, it's contingent. It's not just that poor people have a different view of reality, but that's them, that their reality is different. Let them lie in it. And they were meant to be poor, maybe. That's their reality. Priorities of postmodern society: concern about values as well as evidence, preoccupation with risk rather than benefit, rise of a well-informed patient. It's interesting, in the hospital that I work, as I ride in every morning at 7 o'clock or 7:15, there's a very big notice saying what my rights, if I was a patient, my rights are. Once I'm on the wards, it's a different story. Maybe soon you might want to comment on that in a moment. Our present emphasis on knowledge and skills has produced a technically competent pool of professionals. However, the absence of equally stringent methods for measuring professionalism results in students and doctors needing to consult their own moral compass about what constitutes professional behaviour. So in other words, I become the determinant of my behaviour in the wards and in medicine. Although the ideas of that critical school and evidence-based medicine are widely accepted, controlled experiments are rarely the sole basis on which clinical decisions are made. And indeed, as I was doing ward rounds today, in my hospital, they show me an X-ray. I look at it and I say, a pneumonia. But the other consultant next to me says, oh no, I think that maybe that's cardiac failure, isn't it? So there's a judgment call that is, to some extent, it is evidence-based, but it's not. It's based on my scientific and my background, my knowledge base. So when reading an X-ray, when interpreting laboratory results, when arriving at a clinical diagnosis, there's an observer level. And we try and make it as scientific. 2 minutes. Okay, let's move and finish. So, in fact, let me kind of get to the end of what I'm about. There's an art to doing medicine. And as I read this particular poem in the New England Journal some years ago, a family with a dying son. This is the art of medicine, because medicine is about something intangible that makes a person, makes you, and me. After saying our hellos, we sat in our chairs as the story unfolded. We sank to the floor of a sea. There was too much space between words. Like whitecaps on sea swells, we were fighters knocked out, but still standing. With a reflex swipe at the eye, a hand to the nose, a sniff, following a heave of the diaphragm, we hung on, arms dangling, mouths draped, like discarded jeans. Familiar, but not the regular shape. Our eyes, the shutter open, but no film. Like the primeval rent in the earth's crust, once we were together, then the current of the salt sea broke us off, ripped us apart, each on his own bare continent, alone, with nothing. I think many of us in this room, certainly I have been often in AIDS, in HIV, in oncology when I was an oncologist, in that situation. And there you practice medicine at that level. The art of it, listening, being with people in an hour of need and in a place where science kind of is put on one side, and your humanity has to come to the fore, where you actually almost minister to people. So that, again, Wegner, and I'm ending with this, in the last analysis, I've always believed not so much their subjects that the great teachers teach as it is them themselves. In some box in the attic or up over the garage, I must have notes on lectures I heard by Niebuhr, Tillich, and the rest of them, these great theologians of yesteryear. But though much of what these teachers said remains with me still, it is they themselves who left the deeper mark. I want to say to you as I finish that is what medicine is actually about. Yes, it is about being a good doctor and caring for people and having ethics, but it's about me and the patient. It's something mystical, magical. It's something profoundly deep and moving. And that's why I went into medicine, why you went into medicine, nursing, or into your health profession. And that is what defines medicine. Thank you very much.